Why free flaps? Compared to the pedicle flaps that we have available, we have wider options when it comes to free flaps. For example, you are not tied down by the amount of skin that is required, or muscle that is required, or subcutaneous tissue that is required. We have a wider range of options in free flaps when compared to pedicle flaps. There is no substitute for bone reconstruction when it comes to free flaps. Free flaps are the reconstructive method of choice when it comes to bony reconstruction. We can harvest larger flaps when we do free flaps. We are not restricted by the pedicle or gravity. We can replace multiple components in the defect. We get full 360-degree of movement when you are handling the flap and inserting the flap. And, and you can have a two-team harvest. A simultaneous harvest can be done with the second team harvesting the free flap when the resection is being done. But what are the problems with the free flap? They are more difficult to harvest. You need to be trained in microvascular surgery before you can harvest a free flap. It involves microvascular anastomosis. And even in the highest volume centers, there is still a chance of failure. So we have to be careful that up to 5%, even in the best centers, 5% can have microvascular complications. So pioneering work was done by Taylor and co-workers, where they identified the angiosome concept. Now, when you look at a free flap, the concept is you harvest the source vessels, which lie in the subcutaneous tissue or deep to the subcutaneous tissue or muscle. And these source vessels give out smaller perforators in all directions. Now, if you see here, you can have perforators that go to the muscle and stop there. You can have perforators that go through the muscle and enter the skin. And you can have perforators directly going into the skin itself. So when you have perforators going to the muscle, they are muscular perforators. When you have perforators going from the muscle into the skin, they are musculocutaneous perforators. And when you have perforators directly going to the skin, they are called septocutaneous perforators. Now, if you have a flap that has a musculocutaneous perforator, if you want to separate the tissue and take it along with the source vessel, you have to do intramuscular dissection to reach the source artery and then harvest the flap. But if your flap has an anatomy where there is a septocutaneous perforator, you can spare the muscle and then just raise the subcutaneous tissue and the source artery. So this is another picture of the same. So once the vessel goes from the source vessel or your pedicle vessel, it can go through the different layers of the skin, that is the fascial layer, the subcutaneous layer, the subdermal layer, and then into the skin. And within the skin itself, there are different anastomosing patterns of these vessels. So you have anastomosing patterns in the papillary dermis, you have anastomosing patterns in the reticular dermis, and the subcutaneous tissue also has a plexus, which is just below the deep dermal plexus. Now, the plexus and the subcutaneous tissue is important to remember, because when you have the plexus and the subcutaneous tissue, you can dissect off some of the subcutaneous tissue and thin a flap. Suppose your flap is quite thick, you can thin the flap down, and you can make the flap fit your defect better compared to the thicker donor side. So again, this is another picture showing the direct vessel going into the skin, that is the septocutaneous, and perforators going through the muscle, that is the musculocutaneous. The perfusion of the muscles are also slightly different. You can have different types of perforators going into a muscle. In case you're taking a muscle only flap, you must know the type of vessel that enters the muscle. So you can have one dominant perforator, you can have two moderate sized perforators, you can have two dominant perforators, you can have multiple perforators going, and so forth. So based on this, different muscles have different types of blood supply, and you must know what category your muscle flap falls in to be able to harvest the pedicle as well as the perforator for your inset into your defect. When it comes to bone, bone is quite unique because bone can have blood supply in two ways. One, you can have a direct nutrient artery going into the bone, or you can have blood supply that is running in the periosteum. And where does this periosteal blood supply come from? It again comes from a perforator which travels in the septum. Now we use the word septum a lot. Septum is nothing but a tissue which connects the skin to the bone. All of the bones in the skin in our body is anchored to the bones via the septum. And you can have either the direct nutrient artery supplying the bone, or you can have the nutrient artery via the perforator via the septum supplying the periostea of the bone. So if you preserve either of these two, you will be able to have a vascular bone for anastomosis. Now, these are the different angiosomes. The picture on the right is the different angiosomes in the body. So, what is an angiosome? An angiosome is a four-dimensional structure which has a skin territory, a perforator, and a source vessel. Now, this perforator can supply, if you look at this picture on the left, if you have three different perforators or three different angiosomes, these are the perforators, three different angiosomes. I had mentioned to you the first presentation on pedicle flaps. If you take one perforator, you can capture the angiosome of the second territory without the need of this perforator. So when you raise a free flap on a perforator, you can capture two angiosomes or two skin territories. But the third angiosome you cannot capture because the pressure of the blood that flows through these interconnecting vessels is not sufficient to keep the third angiosome vascular enough. So you must remember very clearly when you're planning to raise a flap, the angiosome of that flap and the skin territory of the adjacent perforator can be harvested, but the angiosome supplied by the third perforator cannot be because of the problem of the pressure of blood flow. So when you broadly like to classify flaps, we classify flaps as fasciocutaneous, that is skin and fascia, fasciocutaneous with muscle, that is ALT, and then I'll come to the different types of flaps next. Or you can have osteocutaneous flaps, which is bone and skin. So in the fasciocutaneous flaps, you have the radial forearm flap, the anterolateral thigh flap, the medial sural artery perforator flap, the lateral arm flap, thoracodorsal artery perforator flap, and the groin flap. If you're looking at a fasciocutaneous with muscle, again the anterolateral thigh flap with the vastus lateralis is a good choice. The latissimus dorsi with the latissimus muscle is another flap where you can raise both skin and muscle. And rectus abdominis, again you have skin and rectus muscle. When it comes to osteocutaneous flaps, we have three that are commonly used. One is the fibula, the deep circumflex iliac artery flap, and the third is the scapular flap. Now, these are some of the examples of fasciocutaneous flap. This is the radial forearm flap. This is anterolateral thigh flap. This is a thoracodorsal artery perforator flap. And this isn't a fasciocutaneous flap. This is a muscular flap alone. This is the vastus muscle with its pedicle. So these are some of the fasciocutaneous and muscle flaps that we can harvest. Bone flaps that we commonly use, as I mentioned, this is the fibular flap. This is the scapular flap, the lateral border of scapula, and this is the deep circumflex iliac artery flap. We will see what are the advantages and disadvantages of each as we go forward. So, free flaps and soft tissue reconstruction. The radial forearm flap is the workhorse flap and has been the workhorse flap for decades now. What we do is we harvest the skin from the forearm. Practically the entire skin from the forearm can be harvested, and this is perfused by the radial artery and its venae comitans. It offers thin, pliable tissue, but it contains hair, which can be a problem, and it's ideal for lateralized tongue defects, defects of the buccal mucosa and the palate. So the radial artery runs between the brachioradialis muscle and the flexor carpi radialis muscle. And if you can, this is the amount of skin that you can harvest. You can harvest a small skin paddle, an intermediate skin paddle, or a large skin paddle. And the skin paddle can go over the radial aspect of the forearm also. So it can cover a decent sized defect in the oral cavity. So take for example, this patient has got a tongue defect. This is a lateral tongue defect where the floor of mouth is still intact. This is the radial artery forearm flap. This is the artery and its venae commitans together, and this is the cephalic vein, and this is the flap that has been inserted. Now, the advantages of the radial forearm flap are that it is thin and pliable tissue. It can be harvested using a tourniquet, which makes the dissection very avascular and helps to control the bleeding. It hardly takes 20 or 30 minutes to harvest a radial forearm flap, but the only downside is the donor site defect. The donor site is usually closed by a skin graft, and this can be unsightly in patients. So, some patients don't prefer the scar on their forearm, and in those patients, we have to look at other alternate flaps for oral cavity reconstruction. But considering all the advantages of the radial forearm flap, uh, I think this is still the workhorse flap for oral cavity reconstruction. The next flap is the lateral arm flap. Now, this is a flap that I like to do and I enjoy doing. Instead of taking skin from the forearm, we take skin from the lateral arm. And this tissue is slightly thicker than the radial forearm tissue. And so if you have a slightly larger defect where you need bulk, you can use a lateral arm flap. But most importantly, the advantage is that you can close the donor site primarily, meaning that there is no skin grafting that is required, and it's usually concealed by the person's clothing. And the vascular supply to this lateral arm flap is by the posterior radial collateral artery, which is a branch of the profunda brachii. So it's a really good flap, but the only problem with this flap is that the vessels are very small. So unless you're comfortable doing microvascular anastomosis to vessels that are 1 to 2 millimeters in size, don't attempt to do this flap. And usually this flap has only one vein compared to the paired venae comitants that the other flaps have. Also, the radial nerve comes in your dissection. You have to be careful not to injure the radial nerve. Otherwise, patients can have problems with that. So this is a lateral arm flap that has been raised on a patient. As I mentioned to you, the thickness of the flap is slightly more compared to the radial forearm. And if you have a slightly larger defect that is extending up to the midline of the tongue, you can really use the lateral arm. In the radial forearm, the length of the pedicle is quite long. So if you have vessels that are lower down in the neck, or if you have an ipsilaterally depleted neck vessel, the radial forearm is the wise choice because the pedicle length is about 10 centimeters at least, and it can easily go to the contralateral neck or to the lower down in the neck to the transverse cervical vessels. The lateral arm has a problem in that the pedicle length isn't much. So unless you have vessels high up in the neck, don't attempt to use the lateral arm because the pedicle might not reach the vessels for anastomosis. This is another flap. The radial forearm and the lateral arm are not true perforator flaps in that we don't dissect out the perforators in them. We leave the attachment of the artery to the undersurface of the skin paddle, and from there, multiple branches of perforators enter into the skin. The medial sural artery perforator flap is a perforator flap, meaning you have to dissect the perforator through the muscle and to the source vessel. So the source vessel here is usually the popliteal artery, and the popliteal artery courses through the gastroc and then gives medial and lateral perforators and supply the skin. We have to dissect the perforator out, follow it up to the popliteal artery, and once sufficient length of the pedicle is obtained, we can divide the vessel there and take it into the neck for anastomosis. Again, the advantage is that the donor site can be closed primarily. It is relatively hairless compared to the other forearm donor sites, and the donor site can be closed primarily. And this is how we take the pedicle into the neck. We use a red rubber catheter. We suture the pedicle to the red rubber catheter and then just pull the pedicle into the neck. And this is how the flap looks after it has been inset. Now, the third flap that we commonly use for oral cavity and tongue reconstruction is the ALT flap. Now, this is a flap that is taken from the thigh, from the lateral aspect of the thigh, and this is a flap that has multiple variations. We can take the flap based on The flap is based on the perforating branches of the descending lateral circumflex artery, which again goes into the profunda femoris. So you can see that the lateral circumflex femoral artery is one branch. It divides into three, that is an ascending, transverse, and a descending branch. And the descending branch is what gives the perforators through the muscle into the skin. Now, the anterolateral thigh flap, majority of the perforators that supply the skin are musculocutaneous perforators, meaning you have to identify the perforator entering the skin and follow the perforator through the muscle all the way up to your source vessel. And then only will you be able to transfer the flap. Now, the ALT is good because if you look at the thigh, you have a large area of skin that you can harvest. If you have the defect, if you have about 8 centimeters of flap that is harvested, you can still close the donor site primarily. And another advantage of the ALT flap is that you can take part of the vastus lateralis muscle, and this can be used to fill in dead space in the oral cavity or in the infratemporal fossa as part of our reconstruction. So the ALT flap is quite versatile. The pedicle length again about 8 centimeters long, depending on where the perforator enters the skin, and the pedicle lumen or the caliber of vessels is also quite good. The perforator variation is very common in the ALT flap, and you have to remember that. There are three types of perforator variations. The first type is when the perforators come from the descending branch of the lateral circumflex femoral, um, and supplies multiple musculocutaneous perforators. There can be perforators coming from the transverse branch of the lateral circumflex femoral artery, or there can be perforators which directly go into the profunda femoris. So you have to be well aware about the different types of perforator variations in the ALT. Not two ALTs are alike. Only when you dissect a large number of ALT flaps will you realize that the perforator anatomy is quite variable. So you have to be prepared to follow the perforator to the source vessel, even if it means that you have to do a lot of intramuscular dissection. So large skin paddle, concealed donor site, can be harvested with skin or skin with vastus muscle. We can use a fascia lata to anchor the flap or to provide structural support to the floor of the mouth. There is minimal donor site morbidity. There's a two-team approach, and you have good caliber of vessels. And here you can see a flap this thick can be really thinned down by cutting out the subcutaneous tissue, but preserving a 1 centimeter cuff of tissue around the perforator. So you have the option of thinning down your flap as much as you want. So for massive glossectomies, the ALT flap can be contoured both in thickness and in transverse and horizontal dimensions. Mouth component, you can have a tonsillar component, and the flap can be quite well inset based on these different components, and the patient can have a good protuberant neo-tongue with good palatal contact, elimination of insensate gutters, and an aesthetically acceptable reconstruction. Again, the ALT flap does not need to be necessarily big in all cases. You can have a small ALT flap also. This is an isolated base of tongue defect. A small ALT flap has been raised. We needed the ALT flap here because the radial forearm and the lateral arm will not provide the bulk that is required. And then the flap can be inset into the posterior third tongue defect, and the vessels can be taken into the neck for anastomosis. The other areas where the radial forearm is particularly useful is for small buccal defects or buccal defects which have a marginal mandibulectomy. You need to reconstruct the cheek mucosa. Unfortunately, skin, and the skin can have hair. And here in the second picture, you can see how far the pedicle extends downwards. So you really have a long pedicle. So the radial forearm is good for tongue, palate, buccal mucosa, and any resection that involves a marginal mandibulectomy. So these are good choices, good defects for a radial forearm flap. But if you have a large buccal mucosal defect where part of the upper alveolus and the hard palate has been excised, and you have a ITF defect also, you can take a large ALT muscle with vastus ALT skin flap with vastus lateralis muscle. Use the vastus to obliterate all the dead space in the infratemporal fossa. Use the skin paddle to close off the cheek defect and give the patient decent aesthesis. Now, I told you that the ALT flap can be, give you a lot of different options. So, case in point is this patient who has an orbital defect, who had a palatal defect, and who had a small cranial defect also. So you can take the ALT flap based on a perforator. You can de-epithelialize the skin between the two skin paddles, one for the palate, one for the socket. You can take vastus lateralis based on two separate perforators and use it to close the dead space in different regions and close off the orbital exentration and the skull-based effect. Now, this is important because no other flap gives you this much of flexibility when it comes to muscle and skin paddle, and you can do that by still preserving a large pedicle that will go to the neck for microvascular anastomosis. The other flap that is good for large oral cavity defects is the tuck flap. The tuck flap is harvested from the medial thigh. It includes a piece transverse skin island and the gracilis muscle with its vascular pedicle. It is quite good for total glossectomy defects. The reason being, this muscle can go transversely to the margins of the mandible. We can anastomose the vascular pedicle in the neck, and we can anastomose the obturator nerve to the hypoglossal nerve to keep this muscle, give tonicity to the muscle so that the muscle doesn't sag, and the patient ends up with a protuberant tongue because of the skin paddle, and the muscle doesn't atrophy because it has been innervated via the obturator nerve and the hypoglossal nerve. So another flap that is good for total glossectomy defects is the tuck flap. So when you have tongue defects that are partial, if you have a lateral tongue defect, then the lateral arm, radial forearm, ALT flap are good flaps that you can do. If you have a tongue defect with floor of mouth defect, the radial forearm is the best choice that you can use because it is thin and pliable. If it's a total glossectomy with an intact suprahyoid musculature and base of tongue, the ALT flap is good. If it's a total glossectomy with absent suprahyoid musculature and base of tongue, you can do an ALT flap or a rectus abdominis. We don't do that many rectus abdominis these days because of donor site morbidity, but an ALT flap or a transverse upper gracilis flap works quite well in these circumstances. But if you have to conceptualize the defects that and what we need to do, so if you have a glossectomy defect, the site of defect and the volume of defect decides the the reconstructive plan. If it's the tip of the tongue, we just don't reconstruct because any free flap reconstruction of the tongue does not, tip reconstruction does not give good results. If it's the lateral border of tongue, you try to preserve mobility and have a lax flap with a flap which has good laxity. If it's an anterior to the defect, you have make sure your flap is anchored well, or you can use the flap and fold it onto itself to give you some bulk. If it's a subtotal glossectomy, you have to replenish the bulk. You have to recreate the oral diaphragm and give it an aesthetic form. And if it's a total glossectomy, again, you have to give the muscle that you use innervation. You can use differential thinning for different sites in the oral cavity. And don't try to suture the skin paddle to the alveolus or the gingiva. Try to keep it as a floating skin paddle so that it granulates and mucosa is formed there. Now, if you have a buccal mucosa defect, if it's mucosa only, a radial forearm flap, an MSAP flap, or a thoracodorsal artery perforator flap are all good options. If you have mucosa with commissure and lip, a radial forearm flap with a palmaris sling is a good option. If you have a cheek defect that is through and through, bipaddle ALT is a good option. And if you have a very large cheek defect with loss of infratemporal fossa contents, the ALT flap with the vastus lateralis muscle will help in obliterating the dead space and covering the bipaddle skin defect. So these are some of the commonly encountered scenarios for using fasciocutaneous flaps. Now let us look at the bony reconstruction that the defects of the bone and the flaps that are available. As I mentioned to you, the three common donor sites are the fibular bone, the scapular bone, and the iliac bone. And all of them have individual advantages and disadvantages. And if you look at the one which has the most advantages is the fibular flap. You have a long bone as long as 25 centimeters with good bone quality, good bone shape. You can harvest a skin pattern along with it. It more or less conforms to the shape of the mandible. You can put dental implants. You have good pedicle length and good pedicle diameter. The next is the scapular flap. It might have a shorter pedicle length compared to the fibula, and the bone quality may not be as good as the fibular flap, but it's a good flap to do, especially if you have short segment defects. So DCIA, the good things about the deep circumflex iliac artery flap is that it has excellent bone quality and excellent shape. The pedicle length is quite short, and the pedicle diameter is also quite small. And you have to dissect through the abdominal walls, and the herniation is a problem once you harvest the DCIA flap. So fibula, scapula, and DCIA are the three common flaps that we use, and I could say with a lot of confidence that the fibular flap is the commonly used flap for all types of bony reconstruction in the head and neck. Now, the fibular flap is a good flap for many reasons. As I mentioned to you before, long bone stock, durable vessels. The good thing about the fibula is that it's got a dual blood supply. So if you look at the cross section of the foot, the fibular flap takes its blood supply from the peroneal vessel. And the peroneal vessels can supply the flap either through a nutrient artery or through the periosteal artery. And after perfusing the bone via a perforator, it supplies the skin also. So you can harvest bone along with skin. So this makes it an osteocutaneous flap. And because of its dual blood supply, if you preserve the periostea and take away intervening segments of bone, you can osteotomize the fibula. So if you take away triangular pieces of bone, you can bend the fibula to form the contour of the mandible that has been lost. So this is a process that is called osteotomizing the fibular flap. And this is only possible because the fibular flap has dual blood supply as compared to the other flaps. So this is the go-to flap for all head and neck reconstruction, bony reconstructions these days. So this is an example, a patient who has had ramus which has been resected, and this is the fibular flap. So you can see here, for the ascending ramus, a triangular piece of intervening fibula has been removed, and the periostea has been left intact on the posterior surface. Because of this intact periosteal bridge between the two fibular segments, the distal segments also retain their vascularity, and by removing a triangular segment of bone here, you can infracture the fibula and you will be able to contour the bone. So both for the ascending ramus as well as the horizontal ramus, by doing osteotomies, it is possible for us to shape the fibula to the shape of the defect. So here you can see the patient who's had a fibular flap, quite normal post-op appearance. Again, the problem is hair growth on the fibular skin paddle, but this can be removed by de-epithelialization. We use a reconstruction plate to mount the fibular fragments. You can see that the shape of the fibula is perfect. And the most important thing is at the end of every bony reconstruction, the occlusion should be in alignment, and that is what has been achieved. So the fibular flap, long bone, ability to osteotomize, the ability to get a skin paddle, and minimal donor site morbidity, all of this makes it the go-to flap for bony reconstruction of the mandible. And because of the adequate bone stock that we have, we can put dental implants and then put a Paris bar, and then the patient can be fully dentally rehabilitated as she was prior to the operation. So when it comes to maxillary reconstruction, we have to ascertain our priorities up front. So maxillectomy can be different types. You can lose the alveolar process, you can lose the nasal process, you can lose the floor of the orbit, or you can lose the zygomatic arch. So you have to ascertain your reconstructive priorities up front and then place the fibular segments where you need them to be. So this is the different ways that you can shape the fibula for the maxillary or orbitomaxillary reconstruction. So you can have the pedicle going downwards, the skin pad lining the oral cavity, or you can have the skin paddle lining the nasal cavity and providing skin paddle for the orbit. You can have skin paddle going into the sulcus in the oral cavity, and you can have bone for the orbit. So you can do a lot of modifications with just the standard fibula, and you can place the bone fragments in any of these or all of these positions and adjust your skin paddle to where the mucosal defect existed, and still be able to take the pedicle into the neck for anastomosis. Sometimes the pedicle in the maxillary reconstruction does not reach the neck, and in those circumstances, we have to be prepared to do the anastomosis to the superficial temporal artery or the superficial temporal vein. Size mismatch is a problem because the peroneal veins are slightly larger than the superficial temporal vein, but it is, in my experience, better to do that than to use a vein graft to take the vessels into the neck. So this is a patient who has a lesion in the right maxilla. Right total maxillectomy has to be performed, and we use 3D virtual planning for all our maxillary reconstructions. So this is a 3D model of the skull with the osteotomized model of the fibula. We don't use reconstruction plates for maxilla. They're simple non-reconstruction plates. For the orbital floor, we use an orbital mesh. Here you can see the fibula has been osteotomized and different segments have been obtained, all attached by periostea. And this is how the bone would have gone into the patient. And this is how the bone is fixed finally into the patient. And the skin paddle goes into the into the oral cavity to resurface the palate. So the ability to osteotomize the bone and provide multiple bone fragments is a very important advantage of the fibular flap. The muscle that you see here is the flexor hallucis longus muscle. You don't have to take the FHL muscle in all cases. In maxillary reconstruction, it becomes difficult to stuff this FHL muscle into a small defect. But the FHL muscle provides an additional a layer of vascularity through the musculo bony perforators. It's good for mandible where there's a lot of dead space to be filled, but for maxilla, I would advise you to raise the fibula without the FHL muscle. So this is the post-op picture of how the patient looks and his CT. So the fibula does allow you to reconstruct the different buttresses of the face following maxillectomies. And the patient also received dental implants and he's been rehabilitated. The next common flap which was popularized in the UK is the deep circumflex iliac artery flap. The deep circumflex iliac artery, which is a branch of the femoral artery and the femoral vein, they supply a vessel which runs on the inner aspect of the iliac bone. And part of the vessel also supplies the internal oblique. I like this flap a lot because it gives you very good bone stock. You can harvest a large vertical height of the iliac bone. The only problem with this flap is that you have to detach a lot of muscles of the anterior abdominal wall and muscles of the thigh from the bone, and the donor side is not good, especially in patients who have a chronic cough or who have COPD or a weak abdominal wall or previous surgery in the abdominal wall. Now, the vessel of the DCIA runs deep to the transversalis fascia of the anterior abdominal wall. So when you harvest the flap, you have to go deep to the transversalis fascia and take a cuff of iliacus muscle. And here, in the normally used DCIA, what we use in clinical practice, we don't take the skin, unlike the fibular flap. Here we take only the internal oblique muscle, and the muscle mucosalizes in the oral cavity, because if you have to harvest the skin, you have look at the course of the perforator. You have to harvest a part of the external oblique also, and this makes the flap very bulky. So a normal DCIA flap would just be the internal oblique and the iliac bone, and in this picture the skin is shown just to show you how much the flap can become bulky if you harvest the DCIA. Now the DCIA has many configurations. You can place it in many different ways. Unlike the fibula where you can osteotomize, here you can only corticotomize, like you can only green stick fracture the bone and not remove wedge shaped pieces of bone. So the natural curvature of the iliac bone fits into different configurations of defects. But normally, if it's an ipsilateral defect, I would use the ipsilateral iliac crest. And it was James Brown who in the 90s popularized this flap. So if you're looking at maxillary reconstruction, you can place the iliac bone like this. The internal oblique goes for the hard palate reconstruction. Must the vessels go to the neck. The vessels are really short, so many a time we have to anastomose to the superficial temporal artery and vein, or you have to use a vein graft. And you can also reconstruct the anterior wall of the maxilla and the floor of the orbit if you take a significantly larger length of bone, vertical height of bone, or you turn the bone in a vertical fashion. So it is possible to do both alveolar as well as subtotal maxillectomy reconstructions by using a DCIA flap. So this is a patient who had upper alveolar defect with a defect in the hard palate and the infratemporal fossa. Here you can see the great amount of vertical bone that you can get. If you compare this with the fibula is nothing because the vertical height of the fibula is incomparable to the vertical height of the DCIA, and this is the internal oblique muscle. We use the bone for the alveolus here, and we use the muscle to mucosalize for the hard palate reconstruction. And this is another patient where we use the DCIA flap for mandibular reconstruction. You can take a large vertical height of the iliac bone, so it's very easy to place dental implants. So this is the iliac bone. This is a pedicle. This is the internal oblique muscle supplied by the ascending branch. And it really matches the native mandible when it comes to the vertical height of bone. This is a bicortical bone, so there is cancerous bone in between, but it takes implants very well, much better compared to the fibular flap. It's very good for implantation, and it is the go-to flap for many centers in the UK. The third set of bone flaps that is more commonly or more recently described has been the scapular system of flaps. The lateral border of the scapula is perfused by the branches from the circumflex scapular artery, which is from the subscapular artery. Now, the circumflex scapular artery gives off numerous periosteal branches to the lateral border of the scapula and also an angular branch to the angle of the scapula. Along with it, there is a transverse cutaneous branch and a descending cutaneous branch. So unlike the DCIA, the skin of the back is relatively thin, so the scapular flap can be harvested along with the skin paddle to resurface mucosal defects intraorally. The only problem with the DCIA, with the scapula as compared to the DCIA and the fibula, is that you have to reposition the patient in a lateral position and free drape the arm so that you can get access to the axilla, because there is a lot of axillary dissection that is required to go up to the origin of the subscapular artery. So these are the options. You take the lateral border of the scapula along with the angle. You can take a transverse skin paddle or a longitudinal skin paddle. If you look at the anatomy of the subscapular system, the subscapular artery is what goes down as the thoracodorsal artery. And the thoracodorsal artery is what supplies the serratus muscle and the latissimus dorsi. So conceptually, you can raise two flaps. You can take the lateral border of scapula with skin, as well as a latissimus dorsi muscle with its skin paddle based on just one subscapular artery. So that is called a scapular megaflap, where you have taken the subscapular artery, you have taken the lateral border of the scapula, the angular branch for the angle of the scapula, the latissimus branch for the latissimus dorsi muscle and its skin, and the transverse and the longitudinal skin paddle. So the subscapular artery allows for multi-axial reconstruction of the bone and soft tissue in the oral cavity. So this picture, the lower picture on the left, is a picture of the scapula that can be harvested. Usually we have to stay below the glenoid fossa, about 1 centimeter below the glenoid fossa. The problem with the scapular flap is that the thickness of the scapula is not uniform like the DCIA or the fibular flap. It is more thick near the glenoid fossa, and the thickness becomes less as you come to the angle. So, if you have to do dental implants of the patient, you have to take a CT scan pre-op, see the thickness of bone, and plan to use that bone where the implants would go in future. So, you would use the bone nearer to the glenoid fossa for implants, whereas this bone is usually quite thin and does not take implants at all. So that is one of the drawbacks, along with having to reposition the bone, and the vascular pedicle isn't as long as the fibular flap. Now, the scapular angle is another flap. I spoke to you about the scapular lateral border. You can take the scapular angle along with the lateral border also, but the scapular angle is a distinct flap. The scapular angle is from the angular branch of the subscapular artery. Now, if you look at the shape of the scapular angle, it more or less resembles the shape of the hard palate. So this is the hard palatal defect here. The shape of the scapular angle more or less mimics the shape of the hard palatal defect. So a scapular angle can be used for hard palate defects based on the angular artery, or the angle can be turned 180 degree and made to reconstruct the anterior wall of the maxilla. The soft tissue reconstruction is by the teres major muscle. The teres major muscle is attached to the lateral border of the scapula and the angular scapula. So you can use the teres major muscle for mucosal defects. And this is how this is one of the patients that I harvested a scapular angle. This is the shape of the angle. So you can see the shape mimics the hard palate. You have teres major muscle here for the soft tissue defects. The biggest advantage is you have a very long skin paddle, a very long um, pedicle. Now, this is a big advantage when you're doing maxillary reconstructions, because most maxillary reconstructions you struggle with the length of the pedicle. So the scapular angle offers a long pedicle for you to be able to reach the neck for anastomosis. So if you have bony defects, and the bony defects are to the maxilla, if it's an orbitomaxillary defect, the fibular flap is still the go-to flap. You can use a DCIA flap if the skin is intact. There are some modifications of the DCIA, that is the DCIA tensor fascial lata iliac internal oblique iliac crest flap, that has also been described. Or you can use a scapular angle with bone graft. If it's an alveolar defect, again, the one that we'd use commonly is a fibular flap followed by DCIA. In mandible, if it's a single axis defect, you can use a fibula or DCIA. In the mandible, if you have to reconstruct the tongue, the alveolus, the lip, multi-axial defects, the scapula can give you multiple soft tissue components. Or if you can get away with a single skin paddle, the fibular flap is still the go-to flap. So in conclusion, you have to look at the body habitus, the nature of the defect, and surgeon comfort to decide the flap that is to be used. Majority of the defects can be reconstructed with the radial forearm ALT or the fibular flap. Pay attention to the donor site and the donor site morbidity. You must have a system of flap monitoring in place and flap re-exploration, because unless you have those two, if the flap shows early signs of congestion or arterial insufficiency, you will not be able to salvage the flap if you don't have facilities for re-exploration. So always have the provision for flap monitoring and re-exploration, and these are mandatory for successful microvascular practice. Thank you for your time.
Thank you, sir. Sir, do you want to continue with the videos you're talking about?
Is based on the radial artery, and it's venae comitans. So always palpate for the radial artery, and you mark a skin paddle around the radial artery. Don't go too ulnar, because if you go too ulnar, you might devascularize the ulnar territory, which is not good. And always do an Allen's test before proceeding to do a radial artery flap. So you make the lateral incision first, and you don't deepen it to the deep fascia. You do a suprafascial dissection, and the, the incision is deepened just so that the fat or the subcutaneous fat has the end of the flap. They can be bipolar. And if you remember, I told you that the pedicle runs between the brachioradialis and the flexor carpi radialis, the FCR. So you have to identify these two tendons. And when you're doing this step, you'll encounter the radial cutaneous nerve at this edge of the flap. So you have to preserve the radial cutaneous nerve. Now the radial cutaneous nerve supplies the snuff box and the dorsum, so you have to preserve that. So this is the radial artery and its venae comitans that has been identified in the deep gutter between the two muscles, and this has to be divided under suture ligation. Don't try to use clips. Try and divide these vessels and then tie them with suture ligation. Once that is done with scissor dissection, you go in a suprafascial plane, meaning you don't violate the paratenon of the tendons. The paratenon of the tendon is a good base for you to place your skin graft at the end of the operation. And here you saw that this is the radial cutaneous nerve. It's usually 2 or 3 branches, so you try and preserve all the branches of the radial cutaneous nerve. Because the paresthesia and the anesthesia that the patients complain of after the operation is quite troublesome for them. So as you go further along the ulnar aspect, you will come to the longest muscle that has to be left back on the patient. So this is palmaris, this is FCR, this is brachioradialis. Then you make the ulnar incision. You can use a knife for most of the incisions here. During your skin incision, you'll also encounter the tributaries of the this side and the cephalic vein on the radial side. I don't take the cephalic vein. I usually leave it back on the patient. So here you can see it's all suprafascial. You don't have to expose any of the tendons. The skin graft take is poor and the skin graft will fail. And as you're lifting up the pedicle, you will see branches from the pedicle entering into the deeper structures. You have to clip them or use bipolar. Otherwise, they'll cause troublesome bleeding once the flap has been inset and has been anastomosed. So here you can see the skin paddle is being elevated off. Try to preserve as much fascia and paratenon on the tendons as possible. So the radial forearm flap can be also harvested as a osteocutaneous flap. So very great. So you might not have good bone if you're looking at thick bone to use. It's quite okay to use for pre-maxillary defects, but otherwise for mandible, it's quite difficult. So then you make a curvilinear incision on the forearm. This is again quite quick using a diathermy. You can just raise the skin. This patient is on a tourniquet at 250, so there is not much bleeding. So the purpose of you elevating the skin here is to be able to identify the pedicle between the brachioradialis and the FCR. You will encounter the cephalic vein when you do this. If you want to preserve the vein, you can preserve the vein. And you'll also encounter the medial and lateral antebrachial cutaneous nerves. If you use these nerves, you can create a sensate flap, but otherwise these can be just cut and the clip can be placed so that they don't form a neuroma. So again, here you see that the skin is being elevated from the tendon and the pedicle is being lifted up from the floor. Which are going into the deeper muscles, and you will have to pay attention and clip each one of them, otherwise the patient will have troublesome bleeding. So here you see the proximal part of the radial artery and its venae comitans. Now people ask me how far you should dissect. Well, you can dissect it till the bifurcation of the radial and ulnar arteries, but it is seldom not required. The advantage of dissecting high up proximally is that the venae comitans increase in size, so you'll have bigger venae comitans for venous anastomosis, or the venae comitans will join the cephalic vein, and you can use the cephalic vein as the vein for anastomosis. So proximal dissection into the antecubital fossa will give you larger caliber veins, or a join the artery, join the cephalic vein, and then you can cut the cephalic vein there and use the cephalic vein for anastomosis, and then that will give you a larger caliber. So this is done in what 15 to 18 minutes. I don't do that much scissor dissection nowadays. It's all done with the cautery. And at the end of the operation, make sure you don't cross clamp the ulnar artery. Make sure you don't violate the bifurcation, because it is the only vessel that is perfusing the hand. So you have to be very careful. So this is the entire pedicle that has been dissected, and the tunicate has been released. And this is how the radial forearm flap is elevated. Next, I would show you the fibular flap harvest. So the fibular flap, the way you mark the fibular flap is that you palpate the Achilles tendon, the tendocalcaneus. The pedicle lies, the septum lies behind the tendocalcaneus, and the soleus muscle in the proximal leg. So you have to mark this line, and the you can Doppler for your perforator. The anterior skin incision should be at least 2 centimeters from tibialis anterior tendon can get exposed and the shin can get exposed. So don't go too far anteriorly. Also, the superficial peroneal nerve can come into your incision, so don't go too anteriorly. Posteriorly, the more you extend, you'll have to encounter the sural nerve and the short saphenous vein. So try to keep your skin paddle the width and length that you require. The use of a Doppler is helpful to localize the perforators, but the septum that attaches between the skin paddle and the bone is usually just behind the tendon. You leave behind about 5 to 6 centimeters of bone of the fibula, both in the knee aspect as well as the ankle aspect. Again, we use the tourniquet. I use the Colorado to make an incision sometimes. So the skin and subcutaneous is incised, and here the deep fascia is incised to expose the peroneal muscle, visual peroneal nerve that I mentioned to you. Don't damage it. It runs quite superficial. So once the skin is elevated off the peroneal tendons, you have to look for the perforators. That is the septum. The gray structure is the septum, and once you do that, here you can see a good sized perforator there, and that will be able to supply the skin pad. Now you'll have to expose the fibula in all aspects. So first you start by raising the peroneal tendon of the fibula. Yeah, once you finish raising the peroneal tendon, you'll have to enter the anterior compartment. So you'll have to incise the septum there and then lift off the EDL and EHL muscles. Now in this compartment, you will come across the antitibial vessel and the deep peroneal nerve. And the purpose of you lifting off this muscle is to expose the interosseous membrane, which is the white structure that you're seeing there. So the anterior tibial vessels and the deep peroneal nerve are from the bone. Next, the posterior skin cut is made, and the skin cut is deepened up to the soleus muscle. Now here you will encounter if the posterior skin cut is far and wide, you might encounter the short saphenous vein and the sural nerve. You can try and preserve those two structures, otherwise they can be ligated. And here too, the deep fascia of the skin of the muscle has to be incised. And then the soleus muscle has to be separated so that the undersurface of the septum comes into view. So once the soleus muscle is separated, you will see the septum on the undersurface, and you will see the FHL muscle. That is the flexor hallucis longus muscle. There will be some branches from the septum going into the soleus muscle. They can be clipped, and the soleus muscle can then be completely separated. So once the soleus muscle is separated, we get into the posterior compartment. Here there might be large veins entering into the gastroc. So you have the soleus and the gastrocnemius muscle. They again have to be clipped or ligated because they tend to bleed once they retract into the muscle. So you go all the way to where you intend for your bone cut. This muscle that you see here is the FHL muscle. And if you look medial to the FHL muscle, you can see the posterior tibial nerve and you can see the peroneal vessel. So these are the, in case, there are some cases where there's a peroneum magna where the anterior tibial posterior vessels, anterior and posterior tibial vessels are absent and the peroneal vessel is the only vessel. But if you see a vessel medial to the posterior tibial nerve, you can be rest assured that the posterior tibial vessels are intact. So here, this is the posterior tibial nerve, and these are those big branches I told you that goes into the soleus muscle. These have to be clipped or ligated. The next step is to do the lower osteotomy. You can use a giggly saw or a reciprocating saw. You have to make sure that you go subperiosteum, form a tunnel and then cut. Superiorly also, you leave about 4 to 5 centimeters. Create a subperiosteal tunnel so that you don't damage the peroneal vessels superiorly. You can put a malleable retractor to preserve and protect the vessels. And then the upper bone is also cut. Then the intraosseous membrane is incised. Once the intraosseous membrane is incised, you can see the distal runoff of the peroneal vessel. Now this has to be ligated. Once you incise the intraosseous membrane, you will come to the tibialis posterior. Now this tibialis posterior is what hides the rest of the pedicle from view. So you'll have to bipolar the tibialis posterior and cut. And as you keep cutting the tibialis posterior, more of the peroneal vessels comes into view. The distal aspect of the FHL muscle, that is the flexor hallucis longus muscle, is cut close to the fibula. If you want to take the full muscle, you have to cut further medially. Otherwise, you stay close to the fibula and cut the flexor hallucis longus muscle so that there's not too much of muscle bulk that is going into the defect. Here you see the peroneal vessels. The tibialis posterior is being bipolar and cut. Medially here, under this muscle will be the posterior tibial nerve. Be careful not to damage it. Now this is further pedicle dissection and further removal of the FHL muscle from the fibula. There are numerous branches from the pedicle into the tibialis posterior muscle on top. They have to be bipolar and controlled, otherwise they will cause bad bleeding. And once you see the appearance of the posterior tibial nerve, that's where the peroneal vessels have bifurcated. So this is where we will have to make the cut for the pedicle. So when you see the posterior tibial nerve, that signifies the bifurcation of the peroneal vessels for our flap. So the FHL muscle is further dissected away. This is how the final bone flap would look like. This is a peroneal vessel entering the bone. This is the posterior tibial nerve. This is the skin paddle, and this is the fibular flap. And then once the tourniquet is released, you can see for the bleeding from the skin paddle. So this is a video of the osteocutaneous fibular flap. Now the final video would be that of ALT flap. Now the way you mark an ALT flap is that the superlateral border of the patella and the anterior superior iliac spine, you draw a straight line. And then there are different ways of doing it, the mid-third, the upper one-third, in the middle two-third. There's a lot of different ways of doing it. But usually what I do is I just raise the anterior skin paddle, identify where the perforator is, and then adjust the rest of the skin incision. Most of these flaps are muscular cutaneous perforators, not septocutaneous. So we will have to dissect through muscle. So this lower incision is usually made, I suggest that this incision is made for beginners, because one of the problems with an ALT flap is that this anterior incision may come over the rectus, instead of coming over the rectus muscle, may come over the vastus muscle, leaving behind the perforators on the thigh. If you make this distal incision first, the tendon that you see after you make this incision is the tendon of the rectus femoris. And that tells you that your incision is on the rectus and you're carefully preserving all the perforators that are coming through the vastus lateralis. So this incision is made, and then the tendon of the rectus is identified. Hence, you know that you're not on the vastus lateralis and you've not disturbed any of the perforators that are coming through the vastus lateralis. Now the skin incision is made, skin and subcutaneous, and you have to incise the deep fascia to expose the muscles. Now the first muscle that you'll expose here is the rectus femoris muscle. It's a bipinnate muscle with the fibers going outward. And once you make the incision on the fascia there, you can start elevating the skin flap. So this is proximal incision on the skin paddle. So this is the rectus femoris, and the vastus lateralis is lateral to that. Once this is the deep fascia or the fascia lata, once that is done, we start dissecting this fascial tissue to identify where the perforators enter into the skin. And then we lift up the rectus femoris so that we are able to see the main pedicle. The main pedicle lies between the rectus femoris. So you can see the main pedicle here, which is the descending branch of the lateral circumflex femoral artery. And there is a perforator which is entering the skin there. And we have to unroof the perforator and follow it all the way up to the main pedicle. So this is the perforator which is entering the skin. And this is the muscle that is covering the perforator. So this is a musculocutaneous perforator. So you raise the muscle off and island the perforator 360 degree. So this is the perforator here going into the skin. So we're doing perforator dissection now. Sometimes the perforators can have a very long intramuscular course. You just have to be patient and dissect the perforator to the main pedicle. There will be a lot of branches to the vastus lateralis, vastus intermedius, rectus femoris. All of them have to be clipped. Otherwise, they might cause bleeding when you insert the flap into the defect. Here you can see the perforator with multiple branches and the perforator going into the main pedicle there. You do not have to skeletonize the perforator completely in all cases. You can leave behind a cuff of muscle around the perforator to protect the perforator. But again, it depends on the size of the defect and how much you can fit into the defect. So this is further perforated section. You have to 360-degree island the perforator. So this is going under the perforator to island it completely. After you island the perforator to 360-degree, you make the incision on the deep fascia. You can either make it from the skin side or from the inner aspect. I prefer to do it from the inner aspect because I have control on where the perforator is entering the skin. Otherwise, the perforator can be in the corner or can be missed. Once the facial artery incision is made, then take care that when you're doing the posterior skin cut, you don't damage the perforator in any way. Otherwise, the flap will be useless. So this is a pretty bulky flap. We can thin the flap by cutting off a lot of the fat and preserving 1 centimeter of intact tissue around the perforator. So this is the AL descending branch of the lateral circumflex femoral artery. And then we check for vascularity of the flap at the end of the operation. I think that finishes the 3 videos I wanted to show.
Okay, sir. The first question on by Dr. Vinayak. The thickness of the lateral forearm flap is bulky. Then can it be used in why it is used in tongue resections?
Yeah, if you want more, suppose the defect is slightly thicker,
Okay,
it's
sir.
more deep, and you want to fill in the defect, then you can use lateral arm flap. The defects which are too small for ALT but too big for radial forearm. In those intermediate cases, you can use the lateral arm flap. So for hemiglossectomy, I think lateral arm is a great flap to use.
So, question by Dr. Nina Ira. Do we need to preserve AMT perforators initially after an ALT flap? If we can't find ALT
Yeah,
perforator, would you prefer to do a freestyle or harvesting of contralateral ALT?
so if your medial incision hasn't violated the AMT perforators, you can still do a AMT flap. But sometimes because the size of the flap which is required might be quite wide, we end up violating the AMT perforator. So if the ALT perforators are not good on one thigh, I would go to the other thigh to raise an ALT. I wouldn't focus my attention on trying to raise an AMT because you would have bipolar all the AMT perforators coming through the rectus or medial to the rectus. So it's very difficult to convert it. I would go to the other thigh for the ALT flap.
Okay, so just wanted to ask you from my side, what is the pre-operative planning? How do you do if the perforators are present or not?
You
Or
can
do
use
you
the
get
Doppler to, the perforators are always there. They are quite constant. You just have to look for them. Otherwise, use a handheld Doppler to do the surface marking and use a handheld Doppler to identify the perforators.
so
That can
what,
give you an idea if the perforators are present.
okay. So what about contrast enhanced angiography to the specific part you want to do?
Yeah, in the West, people have tried for fibula, for ALT, and all of that, but it's expensive, and we generally don't want to add that. So just using Doppler should be okay.
Oh, okay, sir. So another question by Dr. Vinayak, how often do you use pre-operative 3D reconstruction?
Preoperative 3D reconstruction.
Yes, sir.
So for all
3D
maxillas,
reconstruction, 3D CT, 3D CT.
so we are for all our expanded mandibles, secondary mandibular reconstruction, and all maxillary reconstructions. Nowadays, we use the stereolithographic models. We do planning, virtual planning, and create 3D models and do a mock surgery in the lab, and then we do the actual surgery in the theater. So in those cases, it's mandatory to have a 3D VRT of the patient. Otherwise, you cannot create the model. So secondary reconstructions, expanded mandibles where we cannot replate, maxillary reconstructions, we tend to use 3D scans and VRT models for those patients.
Okay, sir. Another question is, in case of peroneum magna, what is your
Yeah.
plan or action of choice in mandibular reconstruction?
So ideally in practice, we should do a CT angio of the leg to rule out peroneal magna, even though the percentage is less than 1%. That is the only vascularity of the foot. So if you compromise that, the patient will have foot ischemia. So ideally, for all cases, a CT angio of the leg is advocated. But if you have a peroneal magna, there can be bilateral peroneal magna also. If you have a peroneal magna on one side, there's a high risk that there's a peroneal magna on the other side. But if you have a CT angio with you, choose a side that does not have the peroneal magna, or go to another flap like the DCIA or scapula. I have seen one peroneal magna in practice, so it's not that it doesn't exist. We found it out through a preoperative CT angio, and then we just used a different flap to reconstruct.
Next
It's
question is
not the
by
peroneal magna which alone is an important thing. The problem is in smokers, patients who have hypertension, and all of that. They can have bad vessel perfusion. They can have narrowing or constrictions of the anterior and posterior tibial vessels. So you can have intraluminal problems which can be picked up by the CT angio. So if you have bad perfusion of or kinking or narrowing of caliber of the vessels, that is also a contraindication for the fibular flap. It's not that peroneal magna alone is a contraindication. If you have any vascular anomaly because of hypertension, atherosclerosis, even that is a contraindication for a fibular flap. So we have to probably in the future it will become more common to use the CT angio to evaluate the fibular flap donor side.
okay, sir. Other question is by Dr. Iqbal. Which material do you used to use as an alternative to fibula on your 3D model templates?
Sorry.
Which flap I think he's asking about. Which flap do you use alternative to fibula on a 3D model template?
The 3D model template, we only use fibula. You can theoretically use capra also if you can print it. Basically, anything that you can print out, you can use. But we only use fibula for 3D modeling and planning. We don't use any other.
Okay, sir. Question by Dr. Neena Ira. How do you choose which leg to be used for harvest fibula flap? And what is your anticoagulant policy in your microsurgery, in your setup?
So, if you suppose a patient has if you want the skin to come and line the mucosa of the fibula, then you use the contralateral fibula. If you want the skin to line the cheek skin, then you use the ipsilateral fibula. This is for mandible. So if the skin is used for the mucosal defect, you choose the contralateral fibula. If the skin is for a skin defect, then you use the ipsilateral fibula. It's exactly opposite for maxilla.
Okay, sir. And the next question is mesh used during the closure of DCIA flap?
Yeah,
And
you
this,
need to use the proline mesh. The mesh has to be hitched close to the remnant internal oblique, and you have to drill holes in the iliac bone and suture it to the remnant of the iliac bone, and you have to darn it to the underlying muscle also. So you have to do a proper mesh repair. And then the patient has to have an abdominal brace for a really long time, laxatives, stool softeners, so that they don't strain and cause hernia issues. So yes, you have to do a mesh repair.
and what are the complications? Can you just tell about the complications that are associated with DCIA, sir? People are asking.
The commonest complication is the hernia. The second problem is the vein that supplies the internal oblique muscle and the vein that supplies the bone. See, the internal oblique is supplied by the ascending branch of the DCIA vessel. The bone is supplied by the DCIA vessel itself. Sometimes the veins do not unite when they enter the femoral vein. So you might end up doing two venous anastomosis and one arterial anastomosis. And the vein is very flimsy because it's a visceral vein. It's very flimsy. It's not like an extremity vein, which is very thick. So the vessels are small. The veins may not unite, and the pedicle length is very short. So
Okay.
these are some of the problems with DCIA.
Next question is how do you reconstruct the condyle? I think the head of the condyle with fibula flap after segmental resection that requires TMJ disarticulation.
You can either do a gap arthrosis. You can leave space there. There will be some drift, but you can use guiding elastics to keep the occlusion, or you can use a free rib graft, or you can use a piece of the fibula itself. But even if you disarticulate, try to keep the articular disc and the capsule intact so that the fibula rests against it. And in benign cases, we have started using condylar substitutes like titanium alloy condylar materials to reconstruct the condyle. That's not for malignant cases, for benign cases. But you can either choose a gap arthropathy, arthroplasty, or you can put a rib graft, or you can use a fibula to go all the way to the glenoid fossa, to the condylar fossa, but make sure that the capsule and the disc can be preserved if possible, so that it doesn't rub against it and migrate.
Sir, there are a couple of questions on your post-application anticoagulant usage. If you are in your institute
So
or
we only use Clexane in an anticoagulant dose, that is zero point 0.2 subcutaneous once a day. We don't use Dextran. And then we scratch the flap every 1 hour on the first day, every 2 hours on the second day, 3 hours third day, and then 6 hour fourth and fifth day. All our patients are in ICU for 5 days. Only then they are shifted to the ward. Any flap compromise within 5 days, we re-explore.
okay. Uh, and what is your experience in using mini plates or recon plates in mandibular reconstruction?
Amrita, we don't use mini plates at all for mandible because you have to use load bearing and not load sharing plates. The mini plates tend to distort, they tend to change shape, and they don't bear the load, especially when the patient has implants and starts chewing. People will argue that the mini plates have less chance of extrusion, easier to bend, and all of that. But we always use only reconstruction plates for mandible. Maybe I will make an exemption in pediatric reconstruction where you cannot use a reconstruction plate. There I might use a mini plate, but otherwise it's always mandibular reconstruction plates.
Okay, sir. One question is a little different. Sir, what do you choose, local plates or free flaps?
When would I
And
choose the flaps
yes, sir.
over?
When do you choose? When do you choose?
So eyelid reconstruction, lip reconstruction, and reconstruction where there are no neck vessels, I would use local flaps.
Okay.
And patients debilitated cannot withstand long anesthesia, obviously. I would do a local flap.
Okay, sir. One more question which you have been explained, but there now the question was, when do you decide the preoperative CT angiography versus arterial Doppler in the lower limb?
I think CT is better because you have a visual image and you have the scans in front of you, and you can measure the size of the vessels and all of those things. So I think CT is probably better. I really don't know what would be the radiologist's perspective, but CT angio is what is commonly described to map out the supply of the vessel. You obviously cannot see velocity and flow and all of those things compared to a Doppler. But I think the standard worldwide has become is to do a CT of the angio, CT angio of the leg, and that also helps us in planning so that we can print a fibula model for our reconstruction.
Okay, sir. And the last question for today is, sir, what is the salvage protocol if a flap fails? Will you do one more free flap or go for a local flap?
So if it's a midline defect of the mandible where you cannot use a pedicle flap, then I would do another fibula. If it's a pediatric patient where you want best cosmetic outcomes, you might end up doing another fibula. Another free flap. Usually we try to salvage our flaps as much as possible. And suppose the defect is in the skull base where the pedicle flap does not reach, then you might end up doing another free flap. So central mandibular defects, pediatrics, craniofacial dissection defects where the pedicle flaps may not reach. And those things I might consider doing definitely, and redo maxilla reconstruction. Definitely consider a free flap compared to pedicle flap.
Sir, one question from my side. We have encountered many post-operative settings, post-irradiated settings where we need to do free flaps, and the arteries in some patients are very friable, and they tend to coagulate immediately intra-op only. By the time we complete and start switching the flap, we can't do it at the same time we re-explore. So one time we had to go till the base of the carotid, external carotid bifurcation. What is your suggestion? What do we do, or how do we assess preoperatively? How to avoid the situation? How to tackle the situations?
It is very difficult. Radiation-induced arthritis is a problem. So you try to do the anastomosis to the opposite side. or try to do the anastomosis to the lower neck, which has not received the 60 gray, which has not been in the 60 gray zone. But prior to embarking on microvascular on any of these flaps, it's always best to explore the vessels first. Make sure you're happy with the vessel caliber and quality, and then only proceed. It's not uncommon. We've had similar problems where the vessel is either has arteriosclerosis or has a lot of adventitial thickening, or they tend to thrombose easily. But you don't know the results of these flaps unless you do the anastomosis. So you're caught in no man's land. So either do it to the contralateral neck or do it to the lower neck. And when you do it to the IJV as end to side, because IJV is very forgiving. And external carotid, try to use the main external carotid. That should also work, but the size mismatch might be there. So you might have to do an end to side on the external carotid. But always explore and expose the vessels. Make sure that they're not thickened or not fibrous and all of those before you make a call on doing a free flap in post-radiated patients, especially chemo-radiated patients.
Okay. One just I want to share in the patient where we had that difficulty, we had to do end to side on the carotid bulb, and the
Yeah,
post-op we had a problem of brady, many episodes of
yeah.
bradycardia. Yeah. Sir, and one
No,
last question.
it's
Yeah,
very
please.
risky to take the carotid bulb, because if you have any problem with the carotid bulb, and if it starts bleeding from there, if the suture gives way, or if there is the patient, stitch gives way, or it's a blow, or patient will die. So it's a very, it's not an easy thing to say that we have done it to the carotid bulb. So
Okay.
you have to be careful to touch that area.
Yeah. So, last question for today, sir. Is there any criteria for bone reconstruction, especially like in pediatric patients?
See, there is no criteria, but the thing about pediatric bone reconstruction is that if you don't reconstruct the bone, either the mandible or the maxilla, the rest of the bony architecture of the face will get altered, and the patient might have their cranial growth gets hindered. But having said that, the fibula, whatever we are transferring, does not have a growth center, because the growth center is not in the part of the fibula that we use. So it is always good, irrespective of the age, it's always good to do a bony reconstruction of the fibula of the mandible or maxilla pediatrics, because you want the rest of the face to also grow, and they should not have any reduction in the normal growth of the face. That's very important.
Uh, sir. So that's it, sir. That's it. All the questions for today, sir. And
Yeah,
thank you very much, sir, for the presentation.
thank you so much for having me here, and thanks for all to all of you for participating also.